Hi everyone, my name is Raffy. I will be giving a lecture on health and medicine. This is part of the lecture series for this year's National Debate Championship. So this is not going to be an exhaustive lecture about all of the topics, because health and medicine is very broad. I have been studying it for the past 6 years. So this is just going to be an overview, and I invite everyone to read up on a lot of the advancements and a lot of the news when it comes to health. This is a topic that I don't think we talk a lot about in our circuit, and I do hope that with this lecture, some understanding from the community might arise. So I hope that my experiences from the Philippine General Hospital can guide or serve as a springboard for everyone to appreciate health and medicine. So these are the objectives for this talk. The first is to introduce important concepts in health, health systems, and the processes to attain health. The second is to briefly discuss key biomedical principles that debaters may use in health or science debates. And I emphasize this because a lot of debates in health also coincide with scientific concepts and vice versa. So a lot of scientific debates might also bleed into health impacts or medical outcomes as well. And the last objective is to also provide resources where health news may arise, as well as special topics of interest in health. This is my outline, so you can remember it with the 5 P's mnemonic. So firstly, we will be defining health and deconstructing health systems. Then the major chunk of this talk will be about public health, patients, providers, peripheral actors, and lastly, principles. And then finally, to close off, I'll be giving special topics and resources that you may access as well. So firstly, let's define health. So according to the World Health Organization, health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So the concept behind this is that health isn't just like the absence of disease, but it's also your lived conditions and your living environments as well. When you go back to the community after you've been cured, for example. But there is also this definition, which is actually one of the underlying principles as well of the World Health Organization. It is also the reference or the resource for a lot of health policy making on the community level, because it is the primary healthcare approach that we would like to call it. So this is the Alma Ata Declaration of 1978, and I also invite everyone to sort of read through it. This is a manifesto done in Alma Ata in this year. Just it was a consensus of different countries agreeing on what health or what the goals for health should be. So according to that document, health, which is a state of complete physical, mental, and social well-being and not merely the absence of disease or infirmity, is a fundamental human right, and that the attainment of the highest possible level of health is a most important worldwide social goal whose realization requires the action of many other social and economic sectors in addition to the health sector. So this passage sort of reveals why I think we should be discussing health in debates. So before we can have IR debates or econ debates, there must be living humans first. And for a human to be alive, obviously they have to attain health as a goal. So that is essentially what the Alma Ata Declaration is talking about. And it's a preview of what the health goals of countries should be. So now that we've defined health, let us deconstruct health systems very briefly. So by health system, it essentially just means like everything that is involved in a person seeking health. So this is also like part of the World Health Organization's like system or model. So there are six building blocks of health systems. So the first would definitely be the governance aspect of it. So in order for any kind of health policy to push through in a society, obviously there is a governing body that pushes legislature and makes policy surrounding healthcare. So if there are bad interventions or there are bad policies, probably there's a governance aspect to that as well. The second building block is your information systems. You especially in times of pandemics, for example, relaying or communicating information between different sectors surrounding health is very important. But not only that, when it comes to research as well, there needs to be good systems to get data or get information about the outcomes of interventions. So, for example, if the Department of Health pushes out a new policy to combat diabetes mellitus, obviously you need to push research into that to know if the intervention is really effective. And for that to happen, you need to have really good information systems, such as like good record keeping or even electronic medical records, for example, and other such information technologies. The third building block would be financing. Obviously, you need money to buy medicines and to buy innovations, technology, and to build hospitals and to build health centers. There are very different financial models, as I'm sure everyone has debated nationalizing healthcare at some point. So it is very important to be aware about the differences in terms of financial system. So for example, although we will not be discussing these per se, the PhilHealth system in the Philippines is radically different from Medicare in the United States. So is the NHS system in the United Kingdom. So it is very crucial to have that awareness about what are the kinds of funding models available for health systems. So there are single payer models, there are public payment models. For example, there are privatized healthcare models as well that everyone should be aware of. The fourth building block is service delivery. So this just means like the actual um like health consult or the actual like going to a hospital, having a consultation there, getting medications and going back and following up, for example. So there's not much like technical detail there. The next building block would be the human resources. So we will also be talking about this in a bit, but essentially everyone who is involved in providing healthcare for an individual is part of human resources. So doctors, your nurses, therapists, etc. And lastly, of course, your medicines and technologies. These are also like very controversial like topics, like when it comes to tech transfers, when it comes to drug discovery and development, medicines and technologies encompass all of those. So your drugs, your interventions, your diagnostics, um, and other kinds of technology available. All right, so those are essentially all of the building blocks of a health system. If you notice, the center of this picture obviously is the people. So uh, again, going back to the Alma Ata Declaration, we always have to ensure that our interventions are people-centered and that they are addressing a specific need of our constituents. Okay, so the next P is public health. So, public health essentially refers to population-based interventions or ensuring that an entire population is healthy and not just like your individual consultations. Um, yeah. So the first topic under public health that I want to focus on would be the levels of prevention and intervention. So under this, there are four essentially like steps on a ladder, right? So we start with primordial up until tertiary levels of prevention. So, okay. So for primordial prevention, this is essentially prevention in instances wherein like the people in a population have no risk factors. Essentially meaning that they are healthy, like they're not obese, they don't have high cholesterol, etc. So this is still prevention because the goal really is to maintain health in order for these people to never develop the risk factors and therefore never develop the diseases alongside them. So the kinds of interventions that you might probably encounter in primordial intervention would be things like health education. So your barangay centers, constantly reminding the public on proper nutrition, on the need for proper exercise or physical activity in order to maintain normal weight or normal BMI would fall under primordial prevention. The next level is primary prevention. This means that the people in your society now have your risk factors. So, for example, they have elevated blood pressure, although it's not high enough to classify under hypertension, or they might be overweight but not obese. So the goal here really is to control these risk factors because they are modifiable lifestyle factors in order for you to prevent disease on a population level. So for example, if you have a lot of overweight individuals, you advise proper nutrition as well. You advise exercise for the goal of weight loss. So for here, you are trying to modify something about their like constituency or their habitus, for example. Whereas in primordial prevention, you're not necessarily modifying anything. You're just teaching them good health behaviors. The next level would be your secondary prevention. So here, because of the risk factors brought about by lifestyle choices like smoking or like improper diet, etc., or like a sedentary lifestyle, secondary prevention means that the people already have those disease. So they are already hypertensive. They're already diabetic. The goal here is to have early detection and early diagnosis in order for you to treat these diseases and like control them and eventually return them into healthy living conditions. So for example, if you have a hypertensive patient or a person with elevated blood pressure, obviously you diagnose them with the whatever the guidelines say on how to diagnose hypertension. It's too technical for this talk anyway, but the main secondary level of prevention here would be to prescribe your BP lowering drugs, for example, your amlodipine or your losartan, in order to drive down the hypertension and eventually return them to normal blood pressure and a normal healthy lifestyle as well. So that is the goal of your secondary prevention. They're already sick, you have to treat them early. The last level of prevention would be tertiary prevention. This means that the people are already very sick, right? These are chronic diseases. So it's all about preventing complications and preventing recurrence of these diseases from arising. This requires more advanced diagnostics and more advanced treatments, but otherwise the goal is fundamentally the same. It is to eventually return the patient into a more healthy lifestyle. So, for example, if your patients or your people in a society have stroke, or because of the hypertension, they eventually have let's say a bleed or a hemorrhagic stroke. So for this disease, what's important in terms of tertiary prevention in order to not have a recurrence of the stroke would be to prescribe them with aspirin maintenance. And what aspirin does in stroke essentially is it sort of waters down. I'm not sure, but it dilutes the blood to ensure that, a stroke doesn't happen again, for example. Okay, so essentially, that's just the gist of the levels of prevention. For public health, it is important to focus on primordial and primary prevention as strategies because secondary and tertiary prevention are mostly in the realm of medicine already. Another concept that I want to introduce in terms of public health would be the social determinants of health. So essentially, as we've stated earlier from the Alma Ata definition of health, health is not just something that arises from one's biology. There's a lot of factors involved. And if you notice in this picture, they actually saw that, or they actually found in studies that a person's overall health can only be derived 20% from healthcare. Whereas the majority of a person's health is determined by the socioeconomic factors. So, for example, if a person is impoverished and undereducated, then probably they won't have good health seeking behaviors, nor will they have like access to healthcare resources because, it costs a lot to seek health most of the time. Therefore, they would probably have like unhealthy lifestyles because they're miseducated, perhaps, or they're probably going to be unhealthy because again they can't go for their regular executive checkups or their regular follow-up consults as well. So that just highlights how important it is to realize that, especially in healthcare debates, these social determinants must always be like a consideration when crafting arguments. Like, what other things outside of this health innovation will impact a person's decision to seek that consultation or to seek that treatment or intervention? So yeah, I think that's it for public health. The next P that we will be discussing will be the patients, those who will be receiving your interventions, either from a public health perspective or from your medical perspective. So, under this topic, I want to highlight the different diseases that might afflict different countries. So, the kind of disease that afflicts a country is actually known as its burden of disease. And in the next following slides, I will be discussing like some differences when it comes to different kinds of populations as well. So, to start off, we'll be discussing the global north versus the global south in terms of the different diseases that affect them. So for the global north, in these countries, because they're richer, we have more advanced technologies. And so, of course, these technologies can detect more complicated diseases earlier. So you will be able to treat them much earlier. And people generally have better socioeconomic conditions, so they have more money to seek those consults, which means a lot of preventable diseases like infectious diseases will actually be eradicated much earlier because of the primary and the primordial prevention that they are much more able to accomplish. Therefore, the diseases that affect the global north are typically lifestyle diseases or what we call non-communicable diseases. So, for example, hypertension, diabetes, and cancer, which are all very prevalent, especially in the West, and obesity, of course, are pertinent problems in the global north. Versus in the global south, where you have like less resources and worse socioeconomic conditions, a lot of the preventable diseases still affect us, right? So there is a prevalence of infectious diseases, or what we term as communicable disease. So, for example, you have a prevalence of infectious diarrhea and malaria in African countries, and you also have a very, very high prevalence of tuberculosis in Southeast Asian countries such as the Philippines. Whereas in the West, if you go there and talk to the doctors, like TB will always be a very good learning opportunity for them because they never experience it in the wards or in their hospitals. But what's interesting is if you look at the top 20 causes of death in the Philippines just last year and 2 years ago, if you notice, we have a prevalence of a lot of non-communicable diseases such as your ischemic heart disease, your cancers or neoplasms, cerebrovascular diseases or stroke, and diabetes mellitus. And there are other non-communicable diseases in this list. But at the same time, you can also observe a lot of infectious diseases like pneumonia and, as I mentioned, respiratory tuberculosis. And lastly, crucially as well, you also have like very curious causes of death, right? Like transport accidents included in the top 20 list. And this is what we term, when you discuss clinical epidemiology, this is what we term as the Philippines having a triple burden of disease. So it's very peculiar, right? So double burden of disease means that you have both non-communicable and communicable diseases in a country. But for the Philippines, uniquely, we have the triple burden of disease, wherein we have communicable diseases, we also have non-communicable diseases, and we also have diseases of rapid urbanization and industrialization. So these diseases include injuries or the previously highlighted transport accidents, or also substance abuse and mental health because of a lack of general awareness from the public about what the detriments of urbanization really are. And the primary reason why there is a triple burden of disease in the Philippines and why there is also a double burden of disease in a lot of countries in Southeast Asia is because of massive socioeconomic disparities and massive lapses in terms of government policy making that make it so because we have um, disparities in healthcare. We have a lot of rich individuals contracting non-communicable diseases, but at the same time, we have a lot of marginalized individuals who contract these infectious diseases. And all of us in the Philippines experience the negative impacts of urbanization and industrialization. We have this clinical picture as to what diseases affect our country. So again, it all boils down to the social determinants as well. That is the socioeconomic context of a country or a society heavily dictates the clinical or um the medical and health related issues that they might also encounter. So another example of this, or although in a much more micro level, when we did our community medicine rotation, there was a very big issue in terms of potable water or like clean water source in the community that we rotated in. So if you notice, a lot of the kids actually from those barangays who did not have clean water for bathing also had concurrent bacterial skin infections because they would like bathe their children with like dirty water. So that's just a demonstration of the alma ata things that we have been discussing in the past or in the past few slides. So just be aware. And hopefully this also sparks some level of creativity when you're contextualizing a certain scenario or when you're having a case study in the upcoming health debates that you might encounter in the future. So aside from the split between the global north and the global south, the diseases that affect each age group also vary. So for the pediatric population or the young ones from 0 to 18 years old, these are mostly infectious or communicable diseases like respiratory tract infections. This is because they are still developing, right? So their immune systems or their resistance against a lot of the pathogens like viruses and bacteria are like their immune system is still like ineffective in terms of clearing or like removing those pathogens from their body. Whereas for adults from 19 to 64 years old, it's a mixture of infectious and non-infectious diseases. So anything goes when it comes to adults. Although again, the triple burden of disease sort of gives you an idea as to what diseases are prevalent in the Philippines. So examples include pulmonary tuberculosis, hypertension, or even goiter. Lastly, for the geriatric population, those who are elderly from 65 and above, um, commonly experience or commonly have chronic diseases like osteoarthritis. Some of them might also have myocardial infarction or heart attack, or again, cerebrovascular disease or strokes, things that are like brought about by the deterioration of a person's body. Those are the things that the geriatric age group encounter or experience. Okay, now that we have discussed or now that I've given you some idea as to like what kinds of disease affect these patients, now let's talk about providers or the health workforce. So who are part of the health workforce? So again, these are doctors who actively treat and manage your diseases, but you can also have your paramedical staff, including your nurses, your midwives, your therapists, occupational, physical, or respiratory, or even speech, your pharmacists as well, who dispense and um, give out your medications, and your dentists. You also have auxiliary staff. So uniquely in the Philippines, we have this concept of barangay health workers, who are the first point or first line, um, first contact of people in the community. So an important topic to discuss perhaps is the process by which a person can become a doctor. And there are also different models when it comes to this. So this is just a table highlighting those differences. So for the United States, it's an 8-year program that requires you to have an undergraduate or a bachelor's degree before you enter medical school. And it needs to be a pre-medical course or program. For their internship, it's actually part of their residency and it is a paid position already. In the United Kingdom, it's only 5 to 6 years because it is considered an undergraduate degree with your MBBS that you can pursue into an MD in terms of the diploma that you receive. The internship really depends on the program that you fall under, but it's generally shorter because you don't have to have a pre-med bachelor's. In the Philippines, conversely, there are two like it sort of combines the both. So the majority of programs in the Philippines will require you to have a pre-med bachelor's degree. So that's 4 years, and then you will have 5 years of medical education. And the fifth year actually is your internship year. It is an unpaid position, unfortunately. But you also have accelerated programs like Intermed, Leap Med in UST. Intermed is in UP Med. Leap Med is in UST. There's also Human Bio in De La Salle, and I think they're also expanding this in Cebu Institute of Med at least, or I'm not sure if it's Cebu Institute of Med. But I do think that there's a program in Cebu already, and there's one in Davao. Um, being in the works as well. So that's 2 years of pre-medical education. These are general courses that they teach you, followed by the 5 years of medical education proper. So after that, you get your license, you take the board exam, and you become a doctor, a licensed doctor. There's also this concept, like when you're training to be a doctor, of being a specialist or being a generalist. General practitioners or GP do not have to undergo specialization training, but you have to train under primary care. These are doctors who can cover most of the diseases of any kind or any age group. But once they're unable to manage patients, they refer them to specialists still. So they have a broad understanding of a lot of diseases. It's just that some of the knowledge of GPs might be superficial, especially if the patient becomes toxic or they have more complicated things, then they won't be able to manage them already. Specialists conversely train under specific programs. So there is the big four specialties. You have internal medicine, pediatrics, OB-GYN, and surgery. And usually specialists cater to more advanced and more complex diseases as well. Okay, specialty training, furthermore, depends on the path that you choose. Generally, the process is to firstly train under a residency program in order for you to be a board certified specialist. This may take anywhere from 3 to 6 years in the Philippines at the very least. After your residency training, you can either stop and just be a specialist or pursue further training under a fellowship program. So after your fellowship program, you will be a subspecialist. You will also be a board certified diplomate after this. And lastly, you can choose to stop after a fellowship, or you can pursue a different or like further training or a focused training under that fellowship as well. So this is an increasing trend. There are no like licensure exams yet for these, but there are definitely sub specialist programs that are available. So for example, I want to be a doctor for children. So I will take a residency in pediatrics for 3 years in the Philippines. Then I will take my fellowship in pediatric infectious diseases for 2 years. Hold on. And finally, if I choose to have a focus in my practice, I can train further under pediatric infectious diseases in immunocompromised patients for 1 to 2 years. So, yeah, it's like a very long and arduous process, but you can stop at any point anyway. Conversely, instead of like further subspecializing, you can also choose to train in two different residencies. So, for example, you can train both as an OB-GYN, and after you take the licensure for OB-GYN, you can then pursue internal medicine. So, it's one after the other. As far as I know, there are no programs that you can take simultaneously. So once that you are a licensed doctor, either as a GP or as a specialist, you then proceed to providing care. And there are different levels of care as well, as highlighted on this slide. So for primary care, this is usually from your primary care providers or PCPs, or even your practice nurses. Primary care refers to the first point of care for individuals in the community. So for example, if you have a barangay health station, there is a practice nurse or a community nurse there, and a person consults because he has been coughing for the past 3 days. They can go to that barangay health station, and that's considered primary care. Secondary care refers to consults done in local hospitals and outpatient clinics. Usually, these are basic diseases. And admission into a hospital can be accounted for under secondary care. But these are just like basic fluids, for example, basic diagnostics. If you need specialized care in terms of more advanced diagnostics, or if you have more advanced and more complex diseases, then you might opt to pursue tertiary care in a specialized hospital with specialists and subspecialists. And lastly, quaternary care refers to care provided by summit hospitals and international health centers. These are more advanced than tertiary hospitals. You might encounter subspecialists here or other more advanced and less accessible diagnostics as well. So again, it's a gradient, right? So accessibility is inversely proportional to the gravity or like the level of care that you're also receiving. So quaternary care is least accessible and primary care is most accessible. Okay. Those are generally the insights that I have for providers. Obviously, when it comes to your paramedical staff, there are also larger discussions about those, especially in the schooling setting, still like your return service agreements, etc. So we can table that for another day. The next topic would be your peripheral actors, and this is going to be brief. This is just a springboard for discussing some potential stakeholders that you might run in debates as well. So, of course, universities are important actors in healthcare debates because universities are the generators of information in a society. And a lot of the hospitals that you might encounter are also attached to universities. So, for example, um, Xavier University and CDO is attached to a hospital. The UPPGH is attached to a university as well, etc. So it's important because you also need to increase incentives for universities to pursue or publish research that are like life-changing or life-saving, and that essentially translates to policies for the next actor. So governments. The incentives of governments are important to characterize in debates concerning financing, or even like regulations when it comes to healthcare. So make sure to have concrete analyses as to why a government might behave in a certain way. The last two actors are more privatized actors. So pharmaceutical companies and insurance companies generally have different market incentives when it comes to protecting individuals in the healthcare sector. So pharmaceutical companies, it's important to discuss different modes of drug discovery, what research priorities these companies would be taking. And for insurance companies, obviously discuss alternative models or incentives that you can give insurance companies to have very good practices when it comes to approving claims from patients. So those are just some of the peripheral actors that you might consider in health debates. The last topic or the last P would be the principles of biomedical ethics that might underpin a lot of the principled argumentation that you run in healthcare debates that you encounter. So, biomedical ethics, or namely, like these principles, these are four principles from the book of Childress and Beauchamp. So, I also encourage everyone to try to read up the source material because it's actually very high yield as well, very interesting. So yeah, let's start this discussion on principles. So the first principle is autonomy. So essentially, it states that patients must be given the right to decide for their healthcare. And the philosophical or the moral reason for this is that patients directly experience their health and must have information about their health. But this only applies if the patients or the people are free from internal pressure or if they are of sound mind and if they are free from external coercion or they're not forced into a medical decision. Otherwise, their consent may actually be vitiated and autonomy cannot be given or cannot be assured for them. So some debate issues that might like spark discussions on autonomy would include things like medical emancipation, patients with terminal illness, patient or transgender patients who are opting for puberty blockers, etc. So anything that has to do with a choice of a patient for their treatment will fall under this. So the next two principles are actually more practical, quote unquote principles. So they apply in most healthcare debates anyway. The first is beneficence, that says that interventions must be done out of the pursuit of cure or comfort all the time. So, for example, instructing interns in your hospital to strictly monitor the vital signs of a patient. Sure, it might be a hassle, but this is pursued for beneficence to ensure that the patients do not clinically deteriorate or you have proper documentation of their vital signs should the need arise. Its sister principle is just the opposite, right? So if beneficence is pursuing a benefit, non-maleficence is not pursuing a harm. So it says that interventions pursued for an individual must be done to avoid harm. It is important to note here that negligence violates non-maleficence for the simple reason that negligence can quickly lead to medical harm for an individual. Let's say if you don't instruct your interns to monitor the vital signs of that patient. Obviously, if the patient deteriorates, you won't have documentation or you won't have proof to like sort of inform your clinical judgment should the need arise because you didn't instruct them. So it's an act of negligence and you actively harmed the patient. So that is important to note. The last principle of biomedical ethics would be justice, that states that interventions must be equitable and must correspond with the lived conditions of the patients being cured. So, so this principle of justice is actually very interesting. It can lead to a vortex of frame battles if used incorrectly, because it's essentially a discussion of who deserves to get treated first. So you have to be very careful in framing it and like underscoring the reasons why the interventions must be prioritized for a certain population over another. So some issues that you might want to consider running a principle on justice would be organ transplantation or donation, or again prioritization on who to give a treatment to, or the issue on triage. Those are some things that might invoke this principle. So those are just like brief explanations of the four biomedical ethics principles. And the last part of the discussion then would be me highlighting some special topics that might be interesting and resources for you to access like health matter. So, of course, end of life care will always be very important, or it will always be very interesting to read up on, especially those with terminal illness and how this might impact their capacity to make decisions. You can also read up on physician-assisted suicide because it's a heavy topic or it's a controversial one when it comes to medical ethics as well. And lastly, for practical reasons, neglected tropical diseases will always be very good to read up on because the Philippines not only has a lot of neglected tropical diseases, but we also happen to be the Asian center for these tropical diseases with the Research Institute for Tropical Medicine in Alabang. So it's very relevant to the Philippine context. Note that these three topics are likely not going to arise in NDC. So these are just for your further learning. Some references that are good, and often where I also encounter a lot of good health matter. The first would be the Lancet family of journals. So the Lancet is like the mother journal, and then there's a lot of like subset journals under it, like the Lancet Western Pacific or the Lancet Microbe. Just search the Lancet journal and many things will arise. It's really good because a lot of the article, no, actually, most of the articles are open access and readily available for the public without charge. And it's good because they also regularly publish editorials, comments, and correspondences. So it's not just like hardcore research studies, it's also like the insights of these experts about key topics and key issues that are arising in several specialties. So it's really good. So browse there. When yeah, it's really good. And a lot of Filipinos publish under the Lancet family of journals. So please support the local research scene. The Economist also surprisingly has like good health matters sometimes. It really depends on the issue. Just look under um the topic of science and tech in the Economist. Sometimes it's AI or like other science topics, and sometimes they're really good health innovations. As far as I know, there was one about CRISPR quite recently, or like several years ago, which was pretty interesting. And lastly, this website, I freaking love science. Obviously, just use the uncensored wording. But this is a really good blog that posts a lot of recent innovations that might be interesting or might be curious or peculiar for the vast majority. It's important to counter check all the time any health matter that you encounter with actual studies or actual evidence, because there's a lot of like fake news online, and we wouldn't want that. But in general, these three resources are my go-to when it comes to health matter. Okay, I think we are at the end of the talk. Thank you very much for sticking with me up until this like ending slide. I am more than happy to entertain any question about this talk, or anything actually about debate. So feel free to reach out either on IG or Twitter. You can also email me or message me on Facebook. So thank you everyone, and best of luck in NDC.